Hi, my name is Hugh Geary. I'm going to be presenting for the University of New England Medical Biochemistry class. I've chosen to present Case 1 on the topic of urea cycle disorders and Case 3 on the topic of gout and uric acid accumulation. Case 1. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be the best to distinguish between a urea cycle disorder and disorder in beta oxidation? Blood glucose, urinary acids, serum fatty acids, or plasma glutamine? So blood glucose is a test that measures blood glucose levels and reflects glucose uptake and efficacy of utilization, as well as glucose production and mobilization. Urea cycle disorders result in inefficient or ineffective conversion of ammonia to urea, which is normally excreted in the urine. We know this would create a buildup of ammonia and upstream intermediates from the point of disorder. Blood glucose levels, while important in diagnosis and determining treatment of various diseases and disorders, are not used as a diagnostic tool in distinguishing a urea cycle disorder. A disorder in fatty acid oxidation would lead to hypoglycemia. This is due to gluconeogenesis requiring ATP and allosteric activators from fatty acid oxidation. However, blood glucose test is not specific enough to identify beta oxidation as the problem. This is especially true in a newborn who may have any number of issues as the cause. We know nothing of our patient's prenatal care history or drugs given to mother during labor. This answer could be helpful in indicating beta oxidation, but not specific enough and does not apply to both types of disorders. So this cannot be our answer for distinguishing between the two. Urinary acids. This is a test that looks at amino acids in the urine. Urea cycle disorders could produce orotic acid in the urine, but so can pyrimidine synthesis deficiencies, but notably urea cycles would have elevated blood ammonia between those two. Urinary acid testing is not a normal diagnostic tool in determining a disorder in beta oxidation. Normal or abnormal fatty acid oxidation would not be determined through urinary acid testing. This answer could be helpful in indicating urea cycle disorders, but does not apply to both of our disorders and cannot be helped in discerning between the two. Serum fatty acids would tell us the level of free fatty acids in circulation. Serum fatty acids won't help us indicate normal or abnormal urea cycle function. Serum fatty acids can tell us if there are fatty acids available for uptake and oxidation, but won't help us distinguish beta oxidation over the urea cycle. This is not our answer. Plasma glutamine. Glutamine is one of the safe nitrogen transporters in the blood. This would tell us the levels of this amino acid in the blood. If there was a disorder in the urea cycle, there would be inefficient or ineffective conversion of ammonia to urea for the subsequent excretion in the urine. Since there is a constant production of ammonia due to deaminations and protein catabolism, glutamine is often used to transport the toxic ammonia through the blood. Glutamine then provides ammonia to the urea cycle. In a urea cycle disorder, glutamine would be elevated due to increased ammonia levels and less activity in the urea cycle. During a disorder of beta oxidation, there is inhibition of gluconeogenesis and lack of energy coming from fatty acid oxidation. The body will be primarily consuming glycogen stores and amino acids that can be directly converted into the TCA cycle intermediates. Glutamate, which is deaminated glutamine, can be converted directly into the TCA cycle. The increase of this amino acid catabolism would lead to reduced plasma glutamine levels in a patient with a disorder of beta oxidation. This test provides a stark comparison between our two disorders and is the only possible correct answer. Now we get further blood workup of our patient. The initial blood ammonia level was elevated at 314 micrograms per deciliter, when normal is between 17 and 80, and rapidly rose to 600. The urine orotic level was markedly elevated at 473 micromoles per liter of creatinine, when it's normally 0 to 3. The plasma citrulline level was normal at 10 micromoles per liter. Normal is 12 to 55, so that's slightly low, but apparently that's still okay. In this patient where orotic acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one that is least likely impaired. So, elevated orotic acid levels indicate there is synthesis of carbamyl phosphate. This is indicated since in pyrimidine synthesis, the upstream substrate from orotic acid and upstream substrate from uric acid is carbamyl phosphate. This indicates that the least likely answer is that the enzyme carbamyl phosphate synthetase is impaired, since carbamyl must be synthesized somehow. Since citrulline levels are not also elevated, the enzymatic deficiency is most likely upstream of citrulline. Combined with our knowledge that carbamyl phosphate is being produced, the most likely answer is the only enzyme between citrulline and carbamyl phosphate, and that's ornithine carbamyl transferase, or ornithine transcarbamylase. Let's move on to case 3. Case 3 is a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms. Blood samples are drawn and urinalysis is performed. The results are his plasma urate was 10.5 milligrams per 100 milliliters, and his urinary uric acid was 214 milligrams per 24 hours. Now his plasma urate is supposed to be less than 7, it was 10.5, and his urinary uric acid was supposed to be around 413 plus or minus 78, and it was low, 215. So what is the best explanation of the presentation of gout in this individual? And please explain why the other choices are not consistent with the data or what additional information you may need to decide. So we're given 3 options: overproduction of purines, decreased salvage of purines, or decreased urinary excretion of the uric acid. So overproduction of purines would lead to increased degradation of excess purines. The end product of this degradation is uric acid, which is transported through the blood and excreted in the urine. In the case of overproduction of purines, we would see elevated plasma urate and elevated urinary uric acid, but our patient has low uric acid, so this can't be the answer. Decreased salvage of urines means there would be an increase in the degradation of purines due to fewer purines being recycled through salvage pathways. This would also lead to a buildup of plasma urate levels and urinary uric acid levels, but our patient again does not have elevated uric acid in his urine, rather low. So this can't be our answer either. Decreased urinary excretion of uric acid would also lead to a buildup. This can happen from competition with lactic acid for excretion, although this is generally related to excess alcohol metabolism, which is not indicated in the info presented to us. Perhaps we need more background on our patient. Another possibility is dysfunction with urate transporters. If there was a decrease in urinary excretion of uric acid, you would expect to see elevated levels of plasma urate as well as decreased levels of urinary uric acid. Now this lines up with our patient's lab values, so this must be the correct answer. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day, and the primary sugar of these sodas is fructose, or high fructose corn syrup. What is the potential impact of this dietary modification on the presentation of gout? High fructose intake, with that 5 liters of soda a day, can lead to increased purine degradation. Fructose is rapidly taken up in the cells by fructose kinase. Fructose's path through the glycolytic pathway is to be split by aldolase B. However, this is a rate-limiting step and causes a buildup of fructose 1-phosphate. This decreases free phosphate and ATP in the cell and increases AMP levels. AMP deaminase converts AMP to IMP, purine degradation increases, and there is also a lack of free phosphate for the salvage of purines, leading to further degradation. Thank you for this wonderful time. I hope you have a good day.